how do you prescribe low vision aids? So that is what everyone is asking and what all of you participants might be very keen and excited to learn. So now there are four steps in providing low vision devices to a patient. Step number one is to record the vision. Step number two is to predict what magnification of device should be given to the patient. And step number three is to select the appropriate device. And the last step is training the client in using the device. So here is a testing kit which we use in our hospital. It's a Keeler set, one for distance and one consisting of telescopes for telescopes and the other telescopes and glasses for near correction. But these two kits are very expensive, and I would not recommend them to you to use, because a lot of cheap and good devices are available, kits are available in the Indian market. So we'd rather go for them. We'll discuss more about those Indian devices and kits later on in this presentation. So there are basically two ways of how to record vision of a low vision patient. The first is that you have to have huge optotypes, like you see in the left-hand schematic. And this is not practical to have these kind of huge wall-mounted optotypes in the clinic. So the other more practical way to do it is to, one, either have special charts made for shorter reading distances, or use the regular chart that we have in our clinics, the Snellen chart, and record vision on that chart. And that last principle is what we follow in our clinic, also in our practice. But for the purpose of completeness of discussion, I'm going to show you a few pictures of the special low vision charts that are available in the market. This is the Keeler distant visual acuity testing chart, and this is the Keeler near vision testing chart. And both of them also have a predictive value, but let us not go into all the details. Just look at the pictures for completeness. And this is the Bailey-Lowy chart, which is for distant visual measurement, and it's a logMAR based chart. And these are also logMAR charts for near vision testing. On the left is the Minnesota Read chart, and the right is the Lighthouse chart. But as I said, we measure vision of low vision patients with a regular Snellen chart, which is found in our clinics. And we test it at a shorter distance. Instead of 20 feet, we test it at 10 feet or 5 feet, or whatever distance the patient is comfortable reading the chart. And then we convert the measured acuity into Snellen notations. To give you an example, you can look at the last line of this slide. So supposing a patient is sitting at 3 meter distance from the chart and can read the third line, his vision will be recorded as 3/24. And then you use a suitable number to convert this into regular Snellen notation. And in this example, it turns out to be 6/48. So that is the Snellen vision recorded on a regular, normal Snellen chart found in all clinics worldwide. So far, so good. So once you've found out the patient vision, you have to prescribe him low vision devices. So there are certain principles to follow. And the first and most important one is that you give him a device which is, first you give him a spectacle correction. And as Dr. Anish Pathan has told you earlier, spectacles will increase the sharpness of the retinal image and make him see better. The second thing to remember is to avoid distant low vision aids if the mobility is good, because if you give a high magnifying telescope, then the mobility is hampered in such individuals. So avoid telescopes if the mobility is good. Distant vision is good enough for allowing mobility in the general environment. The third principle is to prescribe a low vision device which has the lowest useful magnification. Now, how do you determine the magnification? That is the key question. And there are actually two ways of doing it. First is the rule of the thumb, and the second way to do it is to actually calculate and predict the magnification. So the rule of the thumb is that if the visual acuity of a patient is more than 6/60, then usually he would require a 2.5x magnifying telescope. And if the visual acuity is less than 6/60, then generally such a patient would require 6 or 8x magnification in the telescope. So this is the rule of the thumb to predict the the required magnification. The other way to do it is to actually calculate the magnification required. And this is done by first setting a target acuity. You can ask the patient what kind of vision he requires, but if the patient is undecided or you are undecided what target acuity should be, then you can take 612 as a ballpark figure and use this formula, which is magnification required is the desired visual acuity divided by the current visual acuity to arrive at the magnification required. So in this example, which I have mentioned here, if the vision of the patient is 660 and you need to improve it to 66, then the magnification required would be 10x. So that's a simple way of how to calculate and predict the magnification required. But whatever rule you use, whether rule of the thumb or calculation method, and you arrive at a magnification, you have to test the patient with one magnification stepped up and one magnification stepped down and prescribe the low vision device with which the patient is most comfortable with. So likewise, you can also predict the magnification required for near vision devices. And this can be done with the Kestenbaum's rule, which Dr. Kestenbaum formulated in the early 1950s. And according to his rule, if you want to increase the vision of a patient to N8 reading vision, which is good enough to read newspaper print, then you take the reciprocal of his distant visual acuity, and that is the dioptric power of the lens required to produce magnification for him. So in our example, if the vision is 6/60, then if we take the reciprocal of this, then the magnification required would be about 10 diopters or 2.5x, which is good enough to read newsprint. Now to improve the vision furthermore to N6, you multiply the residual vision or reciprocal vision by a factor of 1.4, and for reading N4 or J1, you multiply the reciprocal vision by a factor of 2.8. Now, while you do this, remember that patient also has some kind of accommodation. So you have to subtract the accommodation arbitrarily from this predicted magnification. So for instance, if a child is about 10 years old, then you deduct an accommodation of 8 diopters. And if it's the child is about, of the person is about 20 years old, then you deduct about 6 diopters of accommodation. And at age 50, you deduct about 1 diopter from the calculated value. Now, once you arrive at a magnification for near, how exactly do you prescribe a low vision aid? So for this, one must remember that the first choice should always be a spectacle magnifier for the reasons which have been elaborated very beautifully by Dr. Vivek Singhal. The second choice, of course, would be a hand magnifier. And remember to give stand magnifiers only if the patient has tremors or arthritis and has to do prolonged tasks. Telemicroscopes are prescribed if extended working distances are required. And large print books are recommended when a person can read text which is less than 18 point, even with high ads at least 2 inches distance from the object of regard. CCTVs are prescribed when 18-point text is not visible with high ads of plus 32 diopters. And if all of these fail, then the patient is put up on Braille. The final step in prescribing low vision aids to offer training to the patient in use of the device. So you have the patient come to the clinic and give him the device to use, have him bring some reading material and newspapers or his favorite magazines to read in the hospital and see how he does with the device. Make him move around with the telescope, take him outside the clinic and make him spot distant objects like trees or signboards. And if the patient is comfortable and you and the patient are both satisfied with the device, then you make the final prescription. So the next question which comes to everybody's mind is, where do I get low vision devices and low vision testing kits from? And there are a number of sources available in our country. And the oldest one is Baliwala and Homi from Bombay, Madhu Instruments in Delhi, and Akriti Oculoplastics from Hyderabad, and Lencel Optics in Pune are some of the other sources from where you can buy kits and low vision devices. But remember one thing, low vision rehabilitation is interdisciplinary. And supposing you have a patient who is multiply handicapped or has profound visual loss, especially if it's a child, then you will have to consult other professionals also, like medical doctor, other medical specialists, social workers, special teachers, and occupational therapists. So if you have such a patient, then do not hesitate to refer him to the appropriate specialist. And here is a slide to show you that many places have tactile floors and tactile pavements, especially if you go to advanced countries like Germany, Japan, or America. Even the pavements on or the sidewalks in these countries have tactile floors, so the persons with profound visual loss can move around easily. And on the right hand side, you see pictures of when my new clinic was being constructed, and I had this contrast line incorporated in all the walls, so low vision clients would be able to navigate the galleries in my hospital.